Welcome to EADV Live. Today's topic, botulinum toxin, off-label use in dermatology. I'm Christopher Horskamp, and on behalf of the EADV, we welcome you to today's interactive webcast. If you have questions or comments about the subject matter, send them in at any time during the presentation, and our presenter will do her best to address them at the end. Today, we are joined by our speaker, Professor Ljiljana Medenica. She is currently a consultant at Biomedic in Belgrade, Serbia, and co-chair of the EADV Task Force for Cosmetic Dermatology. She has extensive experience in academia, in practice, and within the European Academy of Dermatology and Venereology. We are happy to have her with us today and happy to hand over the webcast to her. Professor Medenica.
Oh, thank you, Christopher. Good afternoon. You are very, very welcome to our webinar today, Botulinum Toxin off-label use in dermatology. And I would like to thank you to spend this very hot summer afternoon with us. Okay, learning objectives of this webcast are recognized theories for use of botulinum toxin in medical dermatology for different disorders, then identify the best clinical practice for off-label use in dermatology, and also try to identify controversies in use of intramuscular versus intradermal botulinum toxin for facial rejuvenation. As you know very well, botulinum toxin is neurotoxic protein produced by the bacterium Clostridium botulinum. There are 8 types of botulinum toxin named from A to H. Types A and B are capable of causing disease in humans. Botulinum toxin type A is used commercially and medically in dermatology. Botulinum toxin from A to H actually blocks neuromuscular conduction by inhibiting the release of acetylcholine from nerve terminals. Also, it prevents the release of neurotransmitter acetylcholine from exon endings in the neurotransmitter junction. Botulinum toxin A cleaves SNAP25, meaning synaptosome-associated proteins of molecular weight of 25 kilodaltons. On the other hand, botulinum toxin B cleaves VAMP, vesicle-associated membrane protein. Both of them are necessary for the release of acetylcholine from vesicles within the cytoplasm of the motor nerve endings. So, when we are injected botulinum toxin intramuscularly, it produces a localized chemical denervation of the muscle, resulting in localized muscle weakness or paralysis. When we injected botulinum toxin intradermally, actually we target exocrine glands. Botulinum toxin has capability to inhibit acetylcholine release from cholinergic neurons that innervate sweat glands, produce chemical denervation of the smooth muscle surrounding the sweat glands, and reduce sweating. Also, botulinum toxin injected intradermally can inhibit acetylcholine signaling from erector pili muscle, sebocytes, or sebaceous glands by blocking local acetylcholine receptors, alters sebocytes differentiation, and induce decreased sebum production. Also, botulinum toxin injected intradermally can inhibit release of neuropeptides such as substance P, calcitonin gene-related peptide, and vasoactive intestinal polypeptide. Those are produced by sensory nerves in the dermis, and actually they generate pruritus and promote vasodilatation via inducing mast cell to release vasoactive amines. So when we injected intradermally botulinum toxin, we can alleviate itching, reduce, control local skin inflammation and vascular dysfunction. Actually, we can reduce vasodilatation. Botulinum toxin is approved in dermatology. Actually, botulinum toxin, which we can inject it intramuscularly, has a long history of therapeutic application in aesthetic medicine and axillary hyperhidrosis also. On botulinum toxin A, meaning cosmetic allergen, is the first and only neurotoxin indicated for 3 facial treatments area in US. Just for remaining, the FDA initially approved in 2002 botulinum toxin A for the temporary improvement of moderate to severe glabellar lines. Also, it was approved in 2030 for severe crow's feet lines, and finally in 2070 for its third indication for temporary improvement of moderate to severe forehead lines. Of course, the main topic of today's lectures are intradermal injections of botulinum toxin. Dermatological off-label uses of botulinum toxin are really active area of research. The exact mechanism by which botulinum toxin affects disease processes in many dermatological conditions is still unclear. Those areas have shown great promises to date, but more and larger clinical studies will be required before those treatments become clinical reality. So, botulinum toxin can be injected intradermally, and we can see many off-label indications for its use. Actually, this enormous potential of botulinum toxin contributed to a number of broad applications in our dermatology area. It has demonstrated efficacy in a number of rare skin diseases for which there are, unfortunately, a few therapeutic options. Those conditions include numerous diseases that are caused by exacerbated by hyperhidrosis, such as hidradenitis suppurativa, Hailey-Hailey, even dyschrotic eczema, and so many as you can on the list, and also dermatological condition associated with pain and pruritus, such postherpetic neuralgia, leiomyoma, Raynaud, then diabetic neuropathy. There are many studies in this field, lichen simplex chronicus, and others. Okay, we will try to explain mechanisms of action which are relevant for understanding of this very broad therapeutic use in dermatology. So, when we are talking about primary hyperhidrosis, we should mention that botulinum toxin inhibits acetylcholine release from cholinergic neurons that innervate sweat glands, produce chemical denervation of the smooth muscle surrounding the sweat glands, and reduce sweating. Actually, anhidrotic effects is achieved by its action on smooth muscle surrounding the sweat gland, and final outcome is decrease in sweating. And by many anecdotal reports or small studies, efficacy of botulinum toxin introduced on this way can last up to 9 months in primary hyperhidrosis. Hidradenitis suppurativa and action of botulinum in this area can be explained by inhibiting acetylcholine release at post-gangliotic cholinergic synapses with subsequent reduction in sympathetic activation of apocrine sweat glands. Decreasing apocrine gland activity limits tendency of follicular rupture and spreading of follicular material throughout the dermis. So, final outcome is actually reduction of sweat gland production, reducing the population of skin flora and its potential inflammatory effects. By studies and reports, those effects can last 10 to 12 months of complete remission. Also, some authors try to do Botox intradermally in inverse psoriasis, taking into consideration that the botulinum toxin inhibits acetylcholine release from cholinergic neurons that innervate sweat glands and reducing sweating. Also, can inhibit release of substance P because higher concentration of substance P receptors can be found in psoriatic skin, and so reduce vasodilatation and inflammation. And again, a final effect is reduce the erythema extension and intensity and infiltration and also pruritus. The biggest amount of report are about Hailey-Hailey disease. We know that very, very well. That is autosomal dominant disorders as outcome of mutation of the ATP2C1 gene. Frequently, Hailey-Hailey is induced or exacerbated by UV exposure, sweating, friction, and skin infection. Inhibiting acetylcholine release from cholinergic neurons that innervate sweat glands produce chemical degeneration of the smooth muscle surrounding the sweat glands and decrease sweating when we introduce botulinum toxin intradermally. Also, it can inhibit substance P release from the nerve endings and also decrease sweating. Complete remission following second treatment with no further exacerbation with 1 year after the fourth treatment. That is data for many anecdotal reports in the literature. Also, we can use botulinum toxin intradermally to supprime pruritus. Actually, botulinum toxin inhibits the release of acetylcholine from presynaptic vesicles, interacts with each generators such as substance P and calcitonin gene-related peptide, stabilize mast cell and inhibit their degranulation, so reduce the histamine-induced itch intensity. Finally, we can see elevation of itching in lichen simplex chronicus, for example, inverse psoriasis, burn scar, and also hidradenitis suppurativa. Post-herpetic neuralgia can be treated with botulinum toxin thanks to peripheral central mechanism and also direct analgesic effects. Peripheral mechanism acting by inhibition of neuropeptide release from the peripheral nociceptive nerves. Central mechanism exerts central nervous system effects through axonal transport to the CNS after peripheral application. And also, botulinum can give us direct analgesic effects by blocking substance P, neuropeptide, which is involved in pain perception, then vasodilatation and neurogenic inflammation. Also, direct energetic effects going by blocked of glutamate and calcitonin gene-related polypeptide, which is neurotransmitter involved in nociception in the periphery. So, intradermally introduced botulinum can reduce pain, frequency of pain attacks, and even lower pain sensitivity. Except all those mentioned indications, we also like discuss about other possibilities of label use indications of botulinum in dermatology. Encouraging results have been seen with the use of botulinum toxin to improve appearance of hypertrophic and keloid scars, even in scar prevention. Injection of botulinum toxin have been shown significant improvement to reduce signs and symptoms of acne, rosacea, oily skin, and in reduction of large pore size. And on the end, we will like discuss botulinum toxin intradermal injection in full face and neck skin rejuvenation. When we are talking about keloid and hypertrophic scars, we should to know that botulinum inhibits proliferation of fibroblasts derived from hypertrophic scar, suppress the expression of transforming growth factor beta-1, collagen 1 and 3, and also alpha smooth muscle actin and myosin 2 protein in keloid fibroblasts. Also, botulinum can reduce skin tension caused by muscle pull, relieves trapped nerve fibers, neutralizing the itch and pain associated with small fiber neuropathy. So, intradermally used botulinum in keloids and hypertrophic scars decrease erythema, itch, and pain, improve size of the scar, height, and also in duration of the scars. And it is acting on complete remission on the keloids. Even we can use botulinum toxin intradermally for scar prevention because it blocks acetylcholine release from peripheral nerves, allow near complete elimination of dynamic muscle tension on the healing wound, and also if anti-inflammatory effects and its action of the cutaneous vasculature calm down the inflammatory phase immediately or in next 2 to 5 days of wound healing process. Actually, how we are acting to prevent scar. Tension relieving properties plus direct inhibitory effects of botulinum toxin on fibroblasts and TGF-beta1 expression support its usage in surgical scar prevention. There are many reports about action of botulinum in rosacea and facial flushing. A mechanism of action can be explained by blocking acetylcholine release from autonomic peripheral nerves of the cutaneous vasodilatory system, also by inhibition of release of inflammatory mediators that we mentioned before, substance P, CGP, CGRP, and VIP. Actually, botulinum toxin intradermally injected can stabilize mast cells and inhibits their degranulation. In rosacea and facial flushing, we can see reduction and control of local skin inflammation, improvement of vascular dysfunction, and also decreasing of sebaceous activity. Botulinum injected intradermally can also act on oily skin, doing sebum reduction, and also by this kind of injection, we can reduce pore size when we are dealing with large pores. Botulinum blocks local acetylcholine receptors, alters sebum size differentiation, and reduce sebum production. Most likely that arrector pili muscles and the local muscarinic receptors in the sebaceous glands are targets for the neuromodulatory effects of Botox. When we are dealing with oily skin and large pores, finally we can achieve reducing sebum production. So we can expect some therapeutic effects on acne vulgaris and rosacea, particularly glandular type, on oily skin and large pore size reduction. In the last decade, we are talking a lot about face and neck skin rejuvenation by intradermal application of botulinum toxin. Those investigation and using start from Wu in 2000, and we can see it is explained in the literature that botulinum toxin blocks superficial fibers of the underlying facial muscles, orbicularis, frontalis, corrugator, and procerus, can reduce the strength of the depressors also, and reduce wrinkles and lines, but still retaining some movement to avoid the frozen face and paralyzed appearance. So, intradermally injected botulinum toxin can improve skin texture and tone, preserve facial expression more naturally and less frozen, and also it can reduce potency of possibility of mimetic complication, which is very important that we are dealing with botulinum toxin in facial rejuvenation. Botulinum toxin intradermal injection, which we are using in face rejuvenation, has name Microbotox. That is usual name of this kind of procedure. Can be used for full face lifting, forehead lift, eyebrow lift, crow's feet correction, and even lower face and neck rejuvenation. Actually, this introduction of this method in facial rejuvenation challenge conventional techniques of how to deliver Botox to the periorbital and forehead muscle. We can do complementary treatment that will not replace the traditional and known use of Botox. And also, we can see in the literature and in practice of many dermatologists that can be the combination of intramuscular and intradermal injection of botulinum toxin for face rejuvenation. Microbotox, it is actually intradermal use of highly diluted botulinum toxin, which is the new approach, as we mentioned before, to aesthetic treatments of the face, neck, and décolleté, developed by Wu in 2000. Concept of using micro droplets multiple injection points, 0.003 to 0.005 milliliter of Botox, with 0.5 to 0.25 to 0.5 international unit of Botox in this 0.03 milliliter, actually injected into the dermis or the interface between the dermis and superficial surface of the facial muscle, as it does by Wu from the beginning. The injections are delivered intradermally using 30 or 32 gauge needle, raising the tiny blanched papules at each point and 1.5 to 2 centimeters interval. Wu use 0.8 to 1 centimeter intervals, and we are doing multiple injection points. Actually, before any procedure, we should map the area to be treated. Technique, as you mentioned, as you can see on this slide, those are multiple injection points delivered intradermally using 30-32 gauge needles, rising tiny blanching. You can see them, tiny blanching papules at the millimeters 1.5 to 2, intervals of 1.5 to 2 millimeters. You should go an angle of 30 degrees to achieve these intradermally injections and to achieve this tiny blanching papules. And because of different skin thickening, let's go up to 2 millimeters when you're going with intradermal injections of botulinum toxin, when you are going with Microbotox technique. You can see here, for example, for forehead lift, please keep everything, keep this dangerous or safe zone 2 centimeters above the brow, and you can do multiple injection, 1.5 to 2 centimeters, 1 to 1.5 centimeters between points, and achieve the blanching papules. If you are rejuvenate neck or décolleté, you can go you can do a little bit lower interval, 1.1 or 0.8 to 1 centimeter, and go to intradermally depth 2 millimeters, angle 30 degree, very tiny needle, and go up to 2 millimeters. The point is blanching papule. How we can do microbotox? We should dilute botulinum toxin. As you know very well, botulinum toxin, for example, 100 international unit, which is present in Allergan bottle. We do standard dilution with 2.5 milliliters of sodium chloride, and in 0.1 milliliter we achieve 4 international units of Botox. When we add additionally 2.5 milliliters of sodium chloride, we will do double solution, and in 0.1 milliliter we have 2 international units of Botox, or in 0.05 milliliters we have 0.5 international units. Also, we can dilute it more Botox for Microbotox technique. Triple dilution we achieved if we add 5 milliliters of sodium chloride, and then in 0.1 milliliter you have only one international unit of botulinum toxin. And as you can see on this photo, that is the original photo from the first lecture of Wu, how are different drops when you diluted standard dilution, or when you diluted double or triple dilution for the Microbotox technique. Also, you can dilute a Microbotox very, very, very high, adding 10 milliliters of sodium chloride, or combine 9 milliliters of sodium chloride with 1 milliliter of xylocaine. And also, you can use Microbotox as a Mesobotox technique when you actually combine standardly diluted botulinum toxin and add anti-aging mesococktail. For different purposes, you add different number of international units of botulinum toxin. For example, if you like rejuvenate neck and décolleté cleavage, you will add 10 international units of botulinum toxin and 1 milliliter of anti-aging mesococktail. Or if you like achieve global relaxation of face, you can add 20 units of botulinum toxin in 2 milliliters of anti-aging mesococktail, and go on. And also you can combine a small number of units of botulinum toxin, which is diluted in 2 milliliter syringe with 1 milliliter non-cross-linked hyaluronic acid, and add 1 milliliter sodium chloride to additional dilution of botulinum toxin, and you can use this combination perfectly for total skin, for full face rejuvenation, or, for example, for treating large pores. In conclusion, we can tell that the enormous therapeutic potential and promising outcomes of botulinum toxin contributed to a number of broad applications off-label indications, especially in dermatological diseases. A botulinum toxin may be optimally used and an adjacent in recalcitrant cases to conventional therapy for many disorders which we mentioned before on the beginning of the lecture. But also we should consider the limitation of Botox treatment, for example, price. Also, the exact mechanism by which botulinum toxin affects the disease process in many dermatological conditions is still unclear. So, is yet to be learned about the drug and this mechanism of action. Randomized, controlled, prospective trials are still needed to further understanding the efficacy and safety of botulinum toxin in those conditions, and anecdotal and case report data suggested that botulinum toxin is both safe and efficacious. A large number of indications for botulinum toxin off-label use in dermatology are still lacking shared approved protocols for dilution, concentration, total doses, timing of follow-up, and retreatment. The injection techniques, angle, and depth of injections are still debated, depending mostly on the operator's experience. For example, we really need consensus about the dose regimen and injection techniques in desirable for standard, which is we desire that for standardized treatment. Generally, look at this data about Hailey-Hailey disease. That is absolutely different concentration, dilution, retreatment intervals, timing of follow-up. So we need consensus on the dose regimen and injection technique for intradermally injected botulinum toxin. And on the end, just say again, dermatological off-label uses for botulinum toxins are active areas of research. Those areas have shown great promises to date, but more and larger clinical studies will be required before those treatments become a clinical reality. Thank you very much for your attention.
Okay, I think it's time to look at some questions. And it's been an exciting talk already, and we already have a number of questions from members and non-members from around the world.
Thank you.
So some of the first questions we have were about dilution and concentration, but I think you covered that a little bit later in your topic.
Actually, I really covered that in my topic. Dilution, concentration can be diluted double or triple dilution. We usually deal with this kind of dilution, and depends of if we add additionally on the standardly diluted botulinum toxin, if we add additionally 2.5 sodium chloride solution, that will be double. If we add 5 milliliters of sodium chloride, that will be triple dilution. Depends what are you like to achieve. Actually, if you like to achieve not better and worse, but weaker or stronger effects, let's depend actually on that. And of course, you should achieve these small blanching blebs, injected 0.1 milliliter of the botulinum toxin, and in this 0.1 milliliter of botulinum toxin, actually you have 2 international units of botulinum. But let's say maybe for the total face rejuvenation, you can even go with triple dilution, because you are injected a small number of international units in one point size.
Excellent. The questions are rolling in, and actually there's time if our listeners out there have questions, we are still taking them. But we have a question here. Can I use botulinum toxin injection for nail psoriasis?
Oh, I have no data that nail psoriasis can be treated with these botulinum toxin injections, because in their psoriasis, when we use botulinum toxin, we try to reduce sweating, pruritus, and itch. Meaning, I have no data about using of. I don't use it personally, of course. I don't use for nail psoriasis, no, and I didn't saw any data in the literature about this possibility.
Okay. We have another question here. In rosacea, what dose regimen and dilution would you recommend?
Wow, that is very interesting and very difficult question. You can go, depends of, let's say, stage of erythema or stage of sebaceous rosacea, stage of sebaceous hypertrophy. You can go, of course, with double dilution or even triple dilution, especially in the beginning, and go on Intervals, if you ask me, let's see results and see your patient after 1 month, eventually 3 months, and go on with treatment if you achieve results. But it's better go with triple solution in the beginning, triple dilution, sorry, in the beginning.
Okay, now what side effects should we be prepared after mesomicrobotox in the face, if there is any?
Can be side effects can develop. But as we mentioned during the lecture, those side effects are really, really minimized when you when you applied intradermally, especially highly diluted intradermally botulinum in the depth up to 2 millimeters. But of course, you can expect, for example, muscle weakness because you are doing all face. But if you are doing properly, meaning with, for example, triple dilution, and if you correctly give an injection intradermally, do not touch deeper muscle, I mean, probably you will never face any side effects.
Okay, so how many times is it recommended to do the mesomicrobotox?
That's a very, first of all, that's a very, very new name, Mesomicrobotox. The question is, what you like to do? Microbotox, only with diluted botulinum toxin, for all these, before in the lecture mentioned indications, or you like to do Mesobotox? That's actually it's a good question. We should to know if you are dealing with Microbotox, we are dealing only with diluted Botox, double or triple diluted botulinum toxin. And if you are dealing with Mesobotox, and if you call this Mesobotox Mesomicrobotox, you are adding anti-aging mesococktails in these formulas. And you can do that monthly, 2 months, just to go, for example, interval can be 2 months. But also, if something is very, very important, interval can be also 1 month, because for the standard botulinum toxin intramuscular injected, results can last 4 to 6 months. If you are living in a very, very, very hot region, even 3 months, not more than that. But you have to take in consideration that is really diluted Botox, a small number of units, and you should follow your patient. If you, after 1 month, can see still good results, of course, going after 2 months. As I mentioned, no standard for the intervals of the Microbotox or intradermally injected botulinum toxin.
Okay, very good. Now, we have another question. What is the best and safe treatment for alopecia areata in children in a progressive case?
That is a very interesting question, but I think so that is not in so connection with this topic today. Maybe we can discuss that on some other occasion, some other webinar or something like that.
Okay, then let's look over at Raynaud syndrome. How does it work, and do you recommend Botox for it off-label use?
I don't use it personally, but in the literature, you can see anecdotal case report about Raynaud syndrome. If you take in consideration possible mechanism of action of botulinum toxin injected intradermally, you can reduce sweating, you can reduce pain. Actually, I really have no recommendation for this part of it, because reports in the literature are not so much of them, and probably we need time for real recommendation of using Botox in Raynaud syndrome. But as you saw on the table, it is used, but those are anecdotal reports still.
Okay. Can you use BXT in immunological diseases like scleroderma and SLE patients?
Oh my God, can I use? That is, I'm thinking how will act botulinum toxin in scleroderma, and there are reports, but I really do not use that personally. There are reports in the literature, but there is so few of them.
Mm-hmm.
Okay.
Okay, and here's another one coming in. Is there a difference in the incidence of adverse reactions, allergic, with and without a combination of botulinum therapy and mesotherapy?
Just a moment. If there is a difference in the incidence of adverse reaction with and without a combination of botulinum therapy and mesotherapy. Allergic immunologic reaction can develop even if you are giving botulinum toxin, because antibodies can develop. On the other side, you are applying mesotherapy. You have so many ingredients inside, and of course, allergic reaction can develop. But usually, we are not dealing with adverse reaction in, let's say, Microbotox and mesotherapy. Of course, they can develop.
Mm-hmm. We have a comment from one person who is using Mesobotox in steroid-induced rosacea with epidermal techniques instead of intradermal technique and getting significant results. Do you have any thoughts on that?
I'm using my Mesobotox again, meaning probably Microbotox, I hope, because we really, that is 2021. We need to make the difference between Microbotox and Mesobotox. But let's say, okay, I'm using Mesobotox in steroid-induced rosacea with epidermal technique. Epidermal technique meaning probably, I don't know what's mean for this person epidermal technique, but it's probably using much more superficial technique. But in rosacea, the point is to reach there, to go to act on the sebaceous gland, vasoactive amines, and so on, which are producing this. That will be my comment on this one.
Mm-hmm. Okay, we have another question. First, a thank you, and then thank you for your excellent presentation. How many sessions and what amounts would we need in acne scar?
In acne scar, how many sessions? I can give you answer on this question. You should go and follow up your patient. Can be 3, 4, maybe more. Also depends of the depth of the acne scars. And amount, of course, should be diluted double diluted, for example, diluted botulinum toxin. And thank you for your thank you.
Here's a question for this period. How many days should we wait after the COVID-19 vaccinated patients and Botox application?
Wow, that question is, I mean, at least 2 to 3 months, at least. That is more my opinion than, because we really need good recovery after COVID-19 infections. And if we have to wait for other organs, at least 3 months, that will be really fine to wait our skin also. And then we can do, of course, probably this EADV member knows very well that fillers are not suggested during the COVID. Also, but wait at least 3 months for the new application or the second application, whatever.
Excellent. Now we've taken a lot of questions already. I think we'll just take 1 or 2 more. Is that good with you?
1 is okay. Okay,
one more. So let's do this one. And again, we've gotten so many great questions. This has been a superb question and answer session. For aesthetic use, is it safe to use Botox on a vitiligo patient?
You know, if vitiligo is all over the face, I mean, no good question, because no extent studies about this topic.
Right.
Next one.
Actually, I think that's good for today. I think we'll close there. If you have anything else you'd like to say to our audience.
Yeah, thank you. Thank you for being with us with this hot summer afternoon. If you are on beach, please swim for me also. Okay, see you on the next webinar of EADV, and probably Christopher will tell you what is going on in the next week and months.
That's right. Thank you very much, Professor Medenica.
Thank you, Christopher. Thank you.
Not only would we like to thank Professor Medenica, we'd like to thank all of you for being here and for your great questions. It was a very lively, exciting presentation today, and an excellent presentation. We're very, very happy to have had Professor Medenica with us. Now, the EADV is proud to offer numerous opportunities to stay on top of the state-of-the-art in all things dermatology and venereology related. On the 31st of July, we have the application deadline for the EADV-funded clinical fellowship program. For more information, go to www.eadv.org. We would like to remind you that the EADV is now offering face-to-face courses in 2021, after more than a year of tough pandemic restrictions. Apply now at www.eadv.org under Education for the first courses starting in September. And you may find yourself in Lisbon, Barcelona, Malaga, Copenhagen, or Verona, studying among other up-and-coming doctors and specialists in a COVID-safe environment. Seats for specialist doctors are limited and on a first-come, first-served basis. On the 21st of July, join us for our next webcast, Ultrasound Imaging in Cosmetic Dermatology. And at any time, you can check out the Dermatology Podcast, EADV's official podcast, available on all podcast platforms, including Apple and Spotify. Don't forget to follow or subscribe. Thank you again for joining us, and have a pleasant day.